Okay, polycystic renal disease. So this is a inherited disease. So both parents must carry a gene, and it's cysts that form on kidneys. This is a chronic condition. There is no cure for this. It usually starts when they're like really young children and continues developing into their 30s and 40s, and kids have a 50% chance of inheriting this. Both kidneys are usually going to be infected or affected, I'm sorry, instead of just one. So this is going to be bilateral and not unilateral. So these little cysts, they will form on the kidney, and gradually kidney function is going to be destroyed. Assessment is going to be flank pain, microscopic or gross hematuria, proteinuria, polyuria, and nocturia. May have stones, common UTIs, may have hypertension, and a palpable knobby kidney on a physical exam. Diagnostics, it's going to mostly be by ultrasound. Consequences can be renal failure and require dialysis or kidney transplant. Treatments, nursing intervention is going to be mostly aimed towards supportive and grief counseling and coping measures, and then fluid intake of 2,000 to 2,500 to prevent UTIs and stone formation. I have a friend that her daughter has this, and she's about 8 years old right now, and the mom is constantly pushing water. She is not allowed any juice, any pop, any Gatorade, nothing. It's all water and lots of it, because if she doesn't get her minimal water intake for the day, she will have a kidney stone. So it's pretty crazy the things they have to go to and how closely monitoring of their diet they have to do of their child. Acute renal failure. So there's two different types of renal failure. You can have acute or chronic. Acute is going to be typically more severe right away, very timely. And then chronic is going to be a condition that's more insidious. It's going to have a slower onset and typically last longer than 6 months. So in general, you have to think about what kidneys do. They filter out waste. So then you think of those waste products building up in the blood, like creatinine, nitrogen waste, which is going to be measured by the BUN, right? Blood, urea, nitrogen, acid-base balance, electrolyte balance, and fluid balance. So acute renal failure, this is a condition in which kidneys are unable to remove accumulated waste products from the blood. Azotemia, this is a buildup of nitrogenous waste products in the blood. We measure this using the BUN. And then fluid electrolyte acid base imbalance. Causes abrupt decline in kidney function due to injury, trauma, illness, hemorrhage, heart failure, or urinary tract obstruction like a stricture or stone. Drugs and contrast dyes are nephrotoxins, so we need to push fluids and monitor kidney function after those. Sometimes acute renal failure is going to be a reversible condition. If not, it will progress into chronic renal failure. There's typically going to be 3 phases. Initiation phase will have very few symptoms. Maintenance phase will see a sharp drop in that glomerular filtration rate. So glomerular, that's the little part of the nephron that is made of all these little capillaries. And so if those aren't filtering out the blood, that's what their job is to be little itty bitty filters. And if they're not doing that, then we're going to see a huge drop in that filtration rate. We'll also see an increase in BUN and serum creatinine, oliguria, which is less than 30 milliliters of urine an hour for at least 2 hours. Azotemia, this is confusion and disorientation because of that buildup of waste products. And then nausea, vomiting, and diarrhea. Edema from salt retention. They can have hypertension and hyperkalemia, which we'll see with dysrhythmias on the telemetry unit. And then anemia can form because of the lack of erythropoietin that is being given off. That's a hormone that the kidneys need to excrete in order to create red blood cells. So you'll have anemia with that. And then risk for infections are great. Recovery phase, improving kidney function. Urine output starts to balance and lab values start to normalize. It can take up to 1 year for all the healing to be done and to see those values return to normal. Consequences, uremia. This is an accumulation of toxic waste products in the body. It affects multiple organs such as the cardiac system, which causes increased bleeding and risk for infections. Treatment is going to be aimed at preventing infection and, really watching eyes and O's and daily weights and things like that. Chronic renal failure, this is a slow, gradual process of the kidneys going through destruction. They're being, ruined, asymptomatic for years, and then progressing to end-stage renal disease. So those nephrons are becoming destroyed. So for assessment, we have 4 stages. First stage can take months to years. Compensation leads to the patient being asymptomatic. Second stage, we'll see that GFR falls slightly but still symptom-free. Third stage, that GFR moderately decreases, renal function is fragile, infection, etc. may cause the person to jump into that end stage, which is the 4th stage. BUN and creatinine are elevated, GFR is decreased, uremia symptoms, anorexia, nausea, vomiting, confusion, fatigue, insomnia, edema, hypertension, numbness and tingling in hands and feet, dry, itchy, pale, yellow, skin impotence, irregular menses, anemia again, bone tenderness and pain, electrolyte imbalance, and metabolic acidosis. Diagnostics is going to be through a 24-hour urine. So you will start after a void and write down that time. That urine is discarded, that first urine is discarded, and then all the other urine after that is going to be kept, and it needs to be cold. Typically a cooler is going to be kept in the room with ice to put the urine in. Label toilet doors, everything, so that all the hospital staff are aware that we need to be keeping the urine. We don't want somebody that's, physical therapy or somebody just being helpful and taking your patient to the bathroom and they get rid of your urine, because you've got to start all the way over then with the 24-hour collection. Ideally, we like to start this in the morning, right after the first void. That is the start time. And then we want to get one, that morning, the next morning void, and then the time is over at that 24-hour mark. Consequences: hypertension, cardiovascular problems, death, pericarditis from waste buildup, fractures from bone mass changes, reproductive changes, may prevent pregnancy going to full term, may need transplant or dialysis. NSAIDs used with extreme caution. ACE inhibitors and ARBs are used to slow the progression of renal failure. Diuretics such as furosemide can control hypertension and edema and lower those potassium levels. Sodium bicarb and calcium carbonate can be used, especially to help with the pH balance. And then K-exalate, which is an oral rectal suppository to help bring that hyperkalemia down. And then anemia, because often, right, their kidneys aren't excreting that hormone that they need to, the erythropoietin. Erythropoietin, I'm saying it wrong, but anyway, so we need to beef up folic acid, iron, and stimulate that red blood cell production. Statins are also going to be used as well. There's going to be fluid and salt restrictions in this type of diet, an increase in carbs for energy, and then decrease in protein. This is the only diagnosis that we usually see this limit the protein intake. We don't want protein because that's going to damage kidneys further and cause hypertensive issues. Okay, dialysis, really review on your own. We have 2 main types. We have peritoneal dialysis and hemodialysis. Peritoneal, that's where fluid goes into the peritoneal cavity. We call that diacylate. And then fluid comes out. They're at high risk for infection. Peritonitis is a rigid abdomen with a fever. And once that happens, the person then needs to move on to hemodialysis. And that is where blood is pumped from an artery through the dialysis machine. An AV fistula, that's where they've sewn the artery and vein together. And you can feel a thrill or auscultate, listen for what they call a bruit. And diet during dialysis, low protein. Again, protein needs to be kept to a minimum. Low sodium, low phosphorus, and potassium, high carb, and fluid restriction. So there's a picture of the peritoneal dialysis. So the fluid going in, and then things about this is there's a diacylate that goes in, and then there's a drainage bag that comes out, and the drainage bag needs to be lower than the level of where it's draining from in order to have the fluid come in. What you put in needs to be about equal as to what you get out. If you have a significant difference, that you put in way more than you're getting out, then you need to have the patient like reposition, checking for kinks, that kind of thing. All right, last slide here, hemodialysis. So here's a picture of a hemodialysis machine. You can see all the different tubing. And then there's the little filters are on this thing here that the blood will flow through. And here's a picture right here of that AV fistula that you can see where they have sewn the artery and the vein together. All right, this is the end of the last recording for Unit 4A.